So thanks for the warm welcome. So I'm Celestine Shih. I'm one of the new pediatric orthopedic surgeons here at UW. Really excited to be here and to work with all of you. So today we'll go fast and furious because I'm covering a wide diversity of topics in a very short span of time. So if you have any questions, please feel free to ask them later on. I realize I will be covering everything very broadly. So we're going to start off with basic musculoskeletal pathophysiology. How does cerebral palsy affect your bones and joints? So number one, everything comes back to the brain. So because of a neurologic disorder in the brain, you have loss of inhibition of the lower motor neurons. You also have a loss of connection to your lower motor neurons and other pathways. And this results in essentially loss of motor control and weakness, and also can result in other forms of muscular disorders, or sorry, muscular movement disorders like dystonia. Because you have this misconnection between the brain and the muscle, then you develop a muscular imbalance as described in that diagram at the bottom left of the screen. So here you can see when you have normal muscular balance, you have optimal joint function because the joint is balanced. However, when you have abnormal muscular forces, then you develop muscular imbalance leading to joint dysfunction. In the case of cerebral palsy, you have some muscle groups that are overactive, other muscles that are underactive, and then that causes the joint dysfunction. And then this becomes unfortunately, what I would call like a vicious cycle between the bone and the muscle. So bones develop in reaction to mechanical stress, okay? Bones feel compression, tension, shear force, and torsional forces in all four planes of motion. So if you have muscular imbalance in those four planes of motion, that will cause the bone to develop as either twisted or curved or a combination of both. And then because of those abnormal muscular forces, you have abnormal bone development. The bone, if it doesn't develop typically, that can also change the direction or the vector of these muscles, which then further worsens your muscular imbalance, which then further worsens the abnormal mechanical forces acting on the bone, which then further negatively impacts your bone development. And so the vicious cycle continues, okay? So keeping that basic pathophysiology in mind, we'll first start off with the hip and cerebral palsy. This encompasses a wide spectrum of pathology. So on the far left, you have the least involved, which is your hip at risk. You can see here that the acetabulum, also known as the socket of the hip, here it just slightly undercovers the ball, also known as the femoral head. So when you have that mild uncoverage of the femoral head, we call that a hip at risk. When the hip starts to slide out more, we call that a subluxated hip. You can think of it as a partial dislocation, okay? Normally, once the hip passes 40% of migration, meaning more than 40% of the hip is uncovered by the acetabulum, we call that subluxation, and then we start to become really worried, and that's also when we start bringing up the surgery word in our conversations with families. Worst case scenario is on the far right. This is a hip that's dislocated. Worst case scenario is a hip that's dislocated and develops degenerative arthritis, okay? So again, going back to pathophysiology, the brain is the problem. When kids with cerebral palsy are born, their hips are actually normal. This is a patient whose initial x-ray at birth on the far left is a normal hip x-ray. And then as they grew, by the time they reached their preteen years, you can see that the right hip has now become subluxated and is now dysplastic, all right? Again, the brain is the problem. Putting the hips back in place, unfortunately, will not make a child walk. I have to make that clear. A lot of families ask me this question, and unfortunately, it's a misunderstanding. Putting the hips back in place will not make the child walk, okay? So why do we care? We still care because these patients can develop arthritis. If you develop arthritis in your hip, then it becomes harder and more painful to sit in your wheelchair. If you can stand and walk, then having arthritis in your hip makes it painful and difficult for you to bear weight on that arthritic hip, all right? Also, if your hip becomes dislocated or severely subluxated, you develop a contracture where your hip then no longer spreads out enough to accommodate a wheelchair or spreads out enough for you to balance in stance phase. So even though putting the hip back in place will not make a person walk, there are still severe consequences to having a subluxated or dislocated hip. This next slide is a little bit graphic, so if you don't do well with images of live bones and cartilage, you may want to close your eyes, just heads up, okay? So this is what degenerative arthritis looks like. So on the far left is a CT 3D remodeling of a hip that was dislocated. So within this CT scan, we subtracted the acetabulum so that the 3D model shows only the femoral head. And then this is same hip. We had to cut it out because we could no longer rescue it. We had to salvage it. So after we cut out that femoral head, the picture was taken on the right, showing how much cartilage has been worn away and how the bone is completely misshapen and destroyed. This is what we're trying to prevent when we put a hip back in place. We're trying to prevent this arthritis. So how can we manage this? So again, it goes back to your spectrum of severity. So if you just have a hip at risk, then you may be a candidate for proximal femur guided growth. This is our least invasive surgical option. This involves the concept of guided growth, where by tethering the growth plate, pardon me, by tethering the growth plate selectively in one part of the growth plate, then the rest of the bone will continue to grow. And the idea is that we coax the bone to grow back into the hip. All right. It only works for very selective patients. We have to be very careful and wise in who we choose to use these techniques. It's not a silver bullet. It only works in the right age group with the right amount of hip subluxation. All right. If you have a hip that is more subluxated, then you're no longer a candidate for guided growth, unfortunately, because you're past that time window of opportunity. So then the next stage of surgery would be hip reconstruction. That is a typo. I apologize. In the middle section. So instead of proximal femur guided growth, it should be hip reconstruction. This is where we actually cut the bone below the femoral head, and then we reshape it so that it points back into the acetabulum. Sometimes we also have to reshape the acetabulum itself so that it gives more coverage over the femoral head. And then worst case scenario on the far right, that is what we call salvage. That's where we have to completely cut out or resect the femoral head. So moving on now to neuromuscular scoliosis. So this is where you have a curve in your back. This is a picture taken of a patient from the back, and you can see how this patient has a very wide sweeping curve throughout the thoracolumbar spine, causing him to lean to the right, okay? This is affecting his ability to sit in his wheelchair. And this is primarily why we care about neuromuscular scoliosis. So if someone has a pathologic curve in their spine, like that previous patient, then it affects their sitting ability. It can also affect the physical appearance of the patient. It can also be then uncomfortable to sit. It can also affect their breathing if the curve is severe enough. And it can also make it harder to care for them, because imagine if they're hunched over, it's just harder to like eat in general, right? Or even lift up your head to look forward. So how can we manage scoliosis and cerebral palsy? Bracing does not prevent the curve from worsening, but it can improve quality of life by improving the patient's position. So if their curve is flexible, a brace can at least help them sit more comfortably. It can also sometimes delay curve progression, although that's a very mild effect, I would say. Bracing, unfortunately, does not really delay curve progression that much, but it can help a little bit. Surgery is indicated if your curve affects your quality of life, your breathing, or your ability to eat, as I said before. And on the right here is an example of a patient who did have a scoliotic curve of about 118 degrees. She underwent a posterior spinal fusion from T2 to pelvis. Okay, and now you can see her spine is much straighter. Family was very happy afterwards with her positioning in her wheelchair. She could sit upright, she could use her arms again to play games, and she could feed herself. All right, so there are major benefits to spine surgery. However, spine surgery is very complex and it has significant risks. So if your patient or if your child does need spine surgery, you should really consult with a spine surgeon first so we can go over all the risks and benefits with you. All right, there is no one size fits all approach to this. Moving on now, we're going from hips and spine now to the feet. So the feet can either become club feet or flat feet in cerebral palsy, or some variation in between the two. So on one end of the spectrum are flat feet, and here you can see a picture of a patient taken from the back, and you can see how their ankles are rolling in and how their arches have completely collapsed, okay? I will say that most of the time, fortunately, flat feet don't need surgery, okay? The times that flat feet surgery are indicated include, number one, if it's causing pain, all right? Number two, if the feet are so collapsed that the patient has trouble balancing and they need a more stable foundation. Restoring the arch to a foot can give a patient more stability in their feet and therefore a better ability to walk or stand. But again, this requires careful evaluation by an orthopedic surgeon before you start embarking on this journey, because flat foot surgery is also a complex surgery. So why does this happen? Again, going back to our very first slide of pathophysiology, it's because of muscle imbalance caused by disrupted signals from the brain to the muscles. So your posterior tibialis, which is the tendon that supports the arch of your foot, becomes weak. And then the peroneus brevis, which is on the outside of your foot, it is overactive or too strong. And then it starts pulling your foot out and then causing your ankle to roll in. Over time, the soft tissues on the inside of your foot and your arch will stretch and weaken over time. And then if this deformity is progressing over time, the joints of the foot themselves will become rigid, and then your foot is no longer braceable. So how can we manage this? If your flat foot is mild and flexible, sometimes all you need are inserts. Sometimes all you need are braces like the AFO shown here. And then in the more severe cases, like that example I showed before, this was actually one of my own patients. So she had feet that were very flat in that x-ray. As you can see there, she had no arch. So, and she was having pain. She did not have problems balancing, but her surgical indication was pain in the arch of her foot from all the constant pressure of her body weight pressing her foot down into the ground. So we did surgery to restore the arch of her foot. The bottom right shows her post-surgical x-ray. You can see the difference now, how she now has an arch in her foot. And you can clearly see the bones because they're no longer stacked on top of each other. So she did have good pain relief from this surgery, and she worked really, really diligently in rehab to become stronger afterwards. So you can have good outcomes from flat foot surgery, but again, you have to be extremely careful and make sure that it is the right surgery for you and that you're doing it for the right reasons. You're not doing it for cosmetic appearances. You're doing it for pain or for trouble balancing and walking, okay? Now let's go back over to club feet, all right? So club feet is the opposite end of flat feet. Here, this is where oftentimes you have no ability to stand with your foot flat because your foot is so contracted, your heel cord is so tight that you're literally just walking on your toes or walking on the outside of your foot. So this is one of my own patients from Texas, and you can see that she could not put her foot flat on the ground. She was literally just walking on the outside of the ball of her foot, and you can see on her x-rays just how twisted her foot had become. So indications for this surgery are similar to flat foot surgery: pain or difficulty balancing and walking. In a flat foot, you have trouble balancing because your ankles are rolling in so much that your feet are literally just collapsing against the ground. This is the opposite problem. You have trouble balancing, but that's because all of your body weight is resting on one single point. And so you're like trying to be a ballerina. And unfortunately, I think most of us are not ballerinas. We don't have that. I don't have that motor control or balance. So why does this happen? This is the opposite problem of flat foot. So in this case, the muscles on the inside of your arch and the inside of your foot are too strong, so they're pulling your foot in, and the muscles on the outside of your foot are too weak. So then the muscles and the soft tissues on the outside of your foot stretch and weaken over time, and then these joints become rigid and permanently deformed. So how can we manage this? Typically, we recommend diligent stretching when we start to notice a foot developing this type of deformity. I think in flat foot, unfortunately, there's really no good way to stretch the pathologic tendons and muscles except for your heel cord. In this particular case for clubfoot or cavovarus foot, it's different. Here, I think it's easier to stretch those pathologic muscles and tendons. So sometimes just by stretching enough, you can mitigate the progression of deformity or slow it down. If that's not enough, then you add on bracing. An insert does not work in this deformity, okay? Here you have to actually rigidly brace with something like a solid AFO. And then if none of those non-operative modalities work, you have to resort to surgery. Okay, so my patient, the one who, going back, this girl with a severe cavovarus foot deformity, she actually required a two-stage surgery because her foot was so deformed. I mean, you can just see it from that picture. So she required a first stage surgery to lengthen all of the soft tissues, and then I had to stretch her soft tissues in a cast. When I finally got enough, not a lot, but enough flexibility out of the soft tissues, and I maxed that out in the cast, then I had to go back in and do the osteotomies to cut and reshape all of her bones. And she had a really good result. Here you can see now her foot is straight and it's flat on the ground. Okay, so it works well, but this cavovarus foot surgery is actually harder than flat foot surgery. Sometimes it requires a two-stage process, and patients have to understand that. They also have to understand there is intensive rehabilitation afterwards. So to summarize, surgery is not for the lighthearted. You have to know what you're signing up for. Always have a conversation with your surgeon. Sometimes it requires more than one conversation. Okay. And make sure you have a rehab plan after the surgery so that you can maximize your chances of success. So where can I learn more? A really good resource online is called OrthoKids. This is the official patient education website from the Pediatric Orthopedic Society of North America. All of this information has been written by pediatric orthopedic surgeons for families, okay? In this day and age of social media, I realize a lot of misinformation is spread. So hopefully by spreading the word about OrthoKids, you have some information you can actually trust that will give you a better understanding of what you're trying to learn. And then, of course, we are here at American Family Children's Hospital. We now have 4 pediatric orthopedic surgeons, myself included. I specialize in neuromuscular, so that includes cerebral palsy, spina bifida, other conditions similar to those. Happy to meet with any of y'all if you do have questions or would like for me to take a look at y'all. Okay. All right. And I can take questions now. Yeah. Mm-hmm.
If from whenever the child is able to walk,
Mm-hmm.
that they continue to exercise and walk, does that help the hips? Doesn't.
No, it does not. And again, that's unfortunately a common question that I hear. But because of the inherent muscle imbalance, I think that I think that strengthening always helps, right? Staying upright always helps. But unfortunately, you cannot change that seesaw. That seesaw will always be tipped a certain way. All right, like even if you try to strengthen it, one muscle group will always be stronger than the other muscle group. And that underlying muscle imbalance, unfortunately, does not change. And so over time, it will still cause the hips to displace and become dysplastic. Unfortunately, like I said, it all comes down to the brain. So, and as an orthopedic surgeon, I'm dealing with the downstream effects. So whatever I do downstream will not change what is happening upstream. I wish, but that is a really good question.
Do interventions like Botox or baclofen pump? No. Okay. So they're relaxing the muscle doesn't help with that.
No, because again, you're not changing the underlying muscle imbalance. It's like when you Botox, first of all, is temporary, so even if you keep injecting every 3 months, that effect can wear off very quickly, and then you have diminishing returns over time. An intrathecal baclofen pump is wonderful for delaying the progression of hip displacement, but it doesn't prevent it from happening because that underlying muscle imbalance is still there. It's like, yes, you're like turning down the volume, but the music is still playing, if that's a good analogy. So, yeah. But that's also a good question.
Rhizotomy treatments, like what's the relationship of rhizotomy treatments with surgical treatment?
Yeah, so I would say rhizotomy treatment is more like you can think of it along the same lines of an intrathecal baclofen pump. So again, it's going back to that analogy, it's like you can turn down the volume, but you cannot turn it off. Okay. So you still have either upper motor neuron symptoms where you still have that loss of inhibition of the lower motor neurons. And so because you don't have something to like fully remove that spasticity, right? Like the spasticity is still there. You're just trying to modulate it, trying to turn down the volume. But the music is still playing, it's still there. It's still affecting the bones, still affecting the muscles. Rhizotomies are the same way, okay? And because you're not removing, or I should say, you're not completely restoring that inhibition of the lower motor neurons, you still have that underlying hypertonicity negatively affecting the muscles and the tendons and the joints and the bones. So the pathology still develops. Okay, there's been no correlation shown between selective dorsal rhizotomy and prevention of hip dysplasia. There's been no correlation shown between botulinum toxin or prevention of hip dysplasia. There has been no correlation shown between intrathecal baclofen and prevention of hip dysplasia. And these are all unfortunately very, real facts that I have to share. I think these are some of my most difficult conversations with families, Everyone wants their child to do the best they possibly can. But unfortunately, there are limits that we can surgically do to prevent those negative effects from happening.
I was just wondering, so you said that you do like a surgical approach if like braces and such don't work. What would you do as an orthopedic surgeon if surgery did not like provide the results that you were looking for?
So I think that's a very broad question. You have to be a little more specific about what it is that didn't happen, right? Again, it goes back to why are you doing surgery? It's like, are you doing surgery for pain? So as an example, if you have a patient with flat feet, like going back to my patient here who had flat foot surgery, she was having flat foot surgery for pain, but I was very careful in examining her and talking with her to figure out the source of her pain. Okay, if you're not careful and thorough and detailed and thoughtful, then you will misdiagnose someone and then you will do the wrong surgery on them. And sometimes, even though we try our best, that does happen, right? None of us do surgery with ill intention. All of us are just trying to help. Sometimes, though, if you're still having pain, it means you're having pain coming from somewhere else, and then we have to do more workup. Maybe we have to get an MRI, maybe we have to get another CT. The body is this vast interconnected network of nerves, as you all probably understand. And maybe you fix one part of your pain, but maybe you still have pain coming from a different part of your body from a different nerve. Okay, and so that's where we have to do more workup. I hope that answers your question, but it is again, there are many reasons why someone undergoes surgery. So if they don't have the result they expect, it depends on what they were expecting from surgery.
What is the risk of curve progression in cerebral palsy or like neuromuscular scoliosis? And if the curve continues to progress after surgery, what is your next step, or like what are things you consider at that point?
Yeah. So the risk of curve progression depends on your GMFCS level. So if you're GMFCS 1, very rarely do they actually develop neuromuscular scoliosis. And if they do, they have really good results after surgery. It like almost never progresses. If you have a GMFCS 5 patient, though, like this patient over here, this young man, I would say he had a very severe curve, like 100+ degree curve, because he has GMFCS 5. He's completely wheelchair dependent. So the more neurologically involved you are, the higher your GMFCS level, the more likely your curve is to progress. Again, going back to the brain. Your brain is more involved. You have more of everything negatively affecting that innervation pathway between your brain and your muscles. You've got more muscle imbalance, more hypertonia, more scoliosis, okay? And then what do you do if the curve continues to progress? Then it probably means that the spine did not fuse as intended, and then you have to go back and revise the spine fusion. Yeah. I will say, though, that happens very rarely, though, because nowadays, it used to happen more when we had older fixation, like older implants. Now that we have sorry, not modical. Now that we have modern pedicle screw instrumentation and better metallurgy, like stronger rods and stronger screws, we have less risk of hardware failure and we have better fusion rates. So technology has helped us improve that.
Do you ever find that kids benefit or still need bracing after club foot surgery to if they aren't like
Yeah.
fully okay? And then like what level do you recommend, or does it depend on how they're presenting?
I think it depends on how they're presenting.
Mhm.
And I would say after they've had cavovarus foot surgery, so like this. So for example, my patient who had, she had a 2-stage clubfoot correction. She did have to wear a brace afterwards, more for stability because doing this much surgery will weaken the leg. I mean, we're like completely cutting apart, disassembling it, and then reassembling it. So all of the structures become weak and have to become strengthened again through rehabilitation. This is where working with PM&R, like having them like, coordinate the patient's rehab, perhaps in like IRU is super helpful. Throughout that rehabilitation process, typically patients do have to wear a brace to protect the foot, right? Because if you like accidentally fall and twist your ankle, then you're just not good, right? So yes, typically they do have to wear a brace more for stability and protection of the healing structures. And then after they become strong enough, depending on if they still have underlying hypertonia, right? Because again, I'm not taking away the hypertonia. I'm treating the consequences of it. This particular patient, she did still have an overactive posterior tibialis, so she did still have to wear a brace, but she was able to go from an AFO down to an SMO. Does that make sense? And by that point, bracing is more to maintain our correction, not because we're trying to like further correct something. It's more just to maintain our surgical results.
Thank you.
Any other questions? And then I will add one last thing. So this is, so you brought up a really good question about like the bracing and stuff, and it made me think of one more thing. Now we're actually starting, and this was a new technique we were developing at Texas Children's, and then potentially something that we could start working on here at UW. It's combining rhizotomies with orthopedic surgery. Okay. Because again, if you can try to control, you cannot remove, but you can control that underlying spasticity and some of that underlying muscle imbalance. If you can at least control it or temper it, then you can improve the results of your orthopedic surgery, which then gives a patient a more long-lasting success, right? So rhizotomies nowadays, some people are starting to combine that or do selective dorsal rhizotomies ahead of orthopedic surgery. So when the orthopedic surgeon performs their procedure, that underlying hypertonicity is lessened. And then the results of this orthopedic surgery are more durable and successful. Okay. And then another technique that we are now starting to look into is selective neurectomy. Not just dorsal rhizotomy, but neurectomy. And there have been some, again, very preliminary. So very, very preliminary, like slightly experimental. Okay. But this is like cutting edge, is potentially there are some patients who are having really good results when you combine a selective tibial neurectomy with cavovarus foot surgery. Because then by completely removing that I would say hyperinnervation of the tibial nerve, and then when you do your cavovarus foot surgery, you remove that factor of the overactus tibialis anterior, and then your cavovarus foot surgery just becomes that much more successful and long lasting. And then, for example, hopefully then my patient who had this surgery, her foot would hopefully then stay this straight forever. Okay. All right. I think that's my time, but thank you, everybody.